book open
Okay, good.
for tumors, but I haven't run through it yet. So,
Oh, that's
but if you want to hear something, you let me know.
okay. That sounds good.
I'll see if I can look it up in time.
All right. So why don't we start?
Okay, there's so much grading of tumors now that it's really
Yeah, I don't want to.
quite interesting.
Yeah, I don't really want to get into grading of tumors. We don't.
No, I mean it's almost impossible to deal with it in your situation.
Yeah, so I like to look kind of at what their appearance and diagnosis, and then
Yeah.
grading is typically done by the oncologist. Okay. All right. So the WHO classification of bone tumors, and we'll kind of follow this as an outline, are cartilaginous tumors, oncogenic tumors, fibrogenic tumors, fibrohistiocytic tumors, Ewing's and neuroectodermal tumors, hematopoietic tumors, giant cell, notochord, vascular, smooth muscle, lipogenic, neuromiscellaneous, and there are a lot of miscellaneous tumors and tumors around the joint. So it's a big topic. We won't have time. In the past, we used to have time. I've got a lot more cases with the individual joints, but I doubt that we'll have time this year to go through all of the tumor cases. So let's start here. Michael, what do you think of this case?
Alright, so it's right shoulder pain. So you can just say on the left we see a normal shoulder, and then on the right, we have this kind of heterogeneous appearance of the humeral head and the glenoid as well, and similar kind of heterogeneous, like both kind of lytic and almost.
So what you have cortical thickening,
yeah,
a lot of endosteal irregularity, and thickened trabeculae metaphyses, right?
Well, yeah. So in the knee, yeah. And similar findings.
Limited to the
it's all on the right side as well. Is it the same patient on the left, or are you just showing normal? Okay, so everything's been limited to the right side as well. Here's a chest x-ray. From what I can tell, the ribs I think appear okay, and I don't see any. It's hard to tell from this distance, but I don't know if there's any lung pathology.
So it's just the humeral.
Oh, I thought we already talked about it. And then in the skull, looks fairly symmetric. And so now we have an MRI of the right humerus, or right shoulder, I assume. And so we have all these kind of like focal, markedly hypointense foci in the humeral head, as well as throughout the glenoid scapula and in the humeral shaft. Similar findings, just more extensive throughout the humeral head. And so they're pretty dark on fluid-sensitive sequences as well. There's maybe a small area of kind of cystic change, or kind of cystic appearance, or T2 hyperintense appearance.
So what do you think's going on?
Well, it's incredibly multifocal, so I'm not really sure. It doesn't really look like fibrous dysplasia.
Okay, fibrous dysplasia. So what do you think about in terms of sclerosic bone dysplastic lesion? Fibrous dysplasia?
Fibrous dysplasia is one of them.
Osteochondrosis?
It'd be weird because it's unilateral. So
so obviously you want to get a history and all that kind of stuff, and a lot of these wouldn't fit here, but what's on?
It sure looks like this hat has a Paget's type of appearance, doesn't it?
It does. The problem I have.
usually see more skull.
Yeah, that's why they included the CT. So this turned out to be osteopetrosis.
What's interesting is the corticoclavicular ligaments It looks to me like they're calcified. Are they, John? On that one MRI image, a coronal image. Not this one. This one right here. What is that dark structure where the ligaments would be coming down like a triangle?
Are you talking about
from the clavicle? The one on the left.
this?
Yeah, that shadow. What is that?
This is the cortical bone of the scapula here. We're partial voluming.
Oh, I got you. Okay, I didn't get the idea there.
Yeah.
Like the dripping candle going to the periosteal.
Like the osteosis. This usually it's got like.
Yeah. Usually that's not so uniform in thickness. Yeah. Anyway, so there is a you know, kind of a differential here.
This is benign.
Yeah, it's benign, right? So let's go and talk about cartilage tumors. So Ashley, what do you think of this case?
This looks like a pedunculated lesion rising from the distal femur. It looks like an osteochondroma. There's a lot of edema within the adjacent soft tissues, and I think in the musculature.
Okay.
We can see again the osteochondroma. We're not seeing the distal portion is more proximally, and then we can see that there's a lot of edema within the vastus lateralis.
So what are the things that you have to comment upon when you see an osteochondroma?
The cartilaginous cap.
Yeah, the cartilaginous cap, especially if it's more centrally located, especially if it's a multiple osteochondroma, osteochondromatosis. With single osteochondroma in the periphery, the chance of malignancy is extremely low. But you really look, and in adults, really the cartilage cap should go away when the nearest growth cartilage around it goes away. But here what we're seeing, as you pointed out, is the edema in the surrounding muscles, and when they're large like this, you often get traumatic injury to the adjacent muscles, producing the muscle edema, and that's usually the cause of their symptoms from the mass effect of the hard tumor. And then this is just fluid and a bursa due to the repetitive trauma. We can see a little bursa.
That's the size that I would remove, not because I was afraid of cancer so much as just pain and sleeping would be a problem.
Right. Yep. Good.
I would definitely remove this one.
All right, so here we have a mass in the right subtrochanteric region. It looks like there's soft tissue swelling, and there's also some ossification
When you say soft tissue swelling,
just surrounding the mass, focal swelling. Just the way the soft tissue undulates. I think there's some soft tissue swelling. But, so it does have. Okay. So here we do see that it's contiguous with the medullary cavity. So this is most likely an osteochondroma, but it has. I'd be concerned that this could be an developing malignancy because there's a lot of increased signal.
well, this has a typical finger-like projections that you get in large osteochondroma.
Mm-hmm.
I don't really see anything that looks like a focal mass or destructive change. And then we see this large bursa associated with it.
Okay.
Due to trauma with the other tissues. And this is just a very large osteochondroma.
And to see one of these malignant is something to see that I've never seen before. Maybe John has, but I haven't. Single osteochondromas almost, well, I've never seen one reported actually, other than anecdotally.
Yeah, this is getting a little central, but still it would be kind of a peripheral lesion. And in this patient, this was isolated, so we really weren't that concerned about malignancy in this patient. A lot of the literature that describes the rate of malignancy are from referral centers where the data is probably very skewed because they tend to get referred to them, those that are complicated. So they have a much higher malignancy rate in a lot of the reported literature than you're going to see in clinical practice, unless you go to
Yeah, that's what Campbell says.
Okay, so this is kind of a acute chest pain. This is kind of a similar appearing mass in like kind of the left axillary region. It's probably coming off the scapula. I can't really see it. On the right side, there's kind of
There's hold on a second. There's a little bit more to this than the last one.
Yeah. Can we zoom in on it? I really can't see from this far. I can't see from this far. I actually have pretty bad far nearsighted. Yeah, like I'm trying to look at the matrix of that mass on the left. Like if that's like rings and arcs, or it looks like kind of like a chondroid matrix. And then they also have all of that. So that looks like expands. Like, so I don't know if they just have multiple enchondromas and one's differentiated into chondrosarcoma. And so now we have multiple others, and you can see there's all these different enchondromas throughout multiple different bones. So I'm worried.
So what would you say this was right from the get-go?
That this is a chondrosarcoma?
Well, I would say multiple osteochondromatosis.
Yeah.
And possible
degeneration into a chondrosarcoma is what I'd be worrisome for.
Yeah, that's only one lesion that you're concerned about, right?
Yes.
There's the MR.
Okay. Okay, so T1 imaging, we can see the medullary bone extending out, but then we kind of have all this low intensity soft tissue lobulation surrounding it. And it's kind of, this diffuse kind of peripheral type enhancement of it, the lesion. So I don't know if that's just like a giant cartilaginous cap. And if any of it is actually malignant, I am not sure.
It is very common.
Yeah.
Yeah, I had a whole family of these folks at orthopedic hospital way back when, and I never saw a single case of a sarcoma. I had about 30 people in that family that I used to see regularly. And so it's pretty rare even in the multiple osteochondromatosis. It's not very common. Is that your experience, John?
Yes, I think so. And this one I think was all benign. Generally,
Yeah.
when you get malignancy, you certainly have to be concerned about this. I wouldn't call this benign on just looking at the MR scan.
Yeah, I think I would remove this one and block excision is probably the best way instead of trying to take a biopsy. Biopsy sometimes spread tumors. This one I'd take the whole thing out and get rid of it because it's interfering with function probably.
And you wouldn't really know where to biopsy. In a large lesion like this, you could have a focus of a carcinoma, but not biopsy.
Exactly.
So this is osteochondromatosis, 1 in 50,000 typically. And when you see these, you can have a solitary type, which is the most common we see. You get hereditary multiple exostosis like this last case. Then you've got subungual exostosis, which have their own problems in the fingers. And then a bunch of other associated lesions, including the bizarre periosteal osteochondromatous proliferation, which
most of the time you get worried if you suddenly see an increase in sudden growth
Right.
of one of these lesions, that's when you start to get worried.
Yep.
Prior to then, I think you just kind of ride with the waves and ignore them pretty much.
Yeah. And so the things that you want to comment on, osseous deformities, fractures, bursal formation like we've seen in a couple of previous cases, and then impingement on important structures such as tendon, nerves, and vessels, and then finally malignant transformation. So malignant change, it's been described in 3 to 5%, but again, it's generally believed that this is very skewed data. It's probably 10 times less than this. If you see growth after puberty, you should not see growth once the adjacent growth plates have closed. If you see lytic changes within the bone, if you see a soft tissue mass with calcification, if you have a defined cartilage cap and it's greater than 3 centimeters in puberty, this number has varied a lot over the years and depends upon which articles you look at, or 1.5 centimeters in adult. And it's usually focal, not a diffuse kind of thickening.
1.5 is small, really. They get pretty large.
Yeah. And another paper showed that the 1% solitary osteochondroma, 5% per multiple exostoses. Again, I think these numbers are large. Here they use a 2 centimeter for cartilage cap thickening to be concerned about it. And the highest risks are really in the clavicle and the pelvic region, so you have to be concerned about those. Okay, Ashley, what do you think of this case?
John, that 1%, probably they saw one case and that was it.
Yeah, I don't know. I didn't look at the literature for that.
I'm just kidding, kind of.
Yeah.
So along the proximal tibial metadiaphysis, there is a eccentric protrusion extending from the medial aspect. It looks pretty smooth. I don't see that much cortical thickening. Looking at the MRI sequences, again, it is a kind of, you kind of see the lesion, it's kind of serpiginate, or at least, but it is well defined. There's some increased, maybe some very minimal enhancement along the edges right there, yeah, and some increased T2 signal. This almost looks like an osteochondroma to me. I see it here too. It's very clear in the ultrasound, very well demarcated.
So if we go back here, it's in an adolescent. So now let's go to a year and a half later, and this is what it looks like a year and a half later.
Okay, so it's definitely grown significantly from the prior. You can see it's extended along the diaphysis a little bit more. The edges are a little bit more spiculated almost. This is, how old is this patient again?
It's an adolescent. It's in the teenage years. I don't know how old.
Okay, so this is, I mean,
now notice how
during puberty.
scalloping here, but it's kind of corticated. It's not, usually if you have a destructive lesion, you won't see this cortication next to it. Here's the MR scan now, a year and a half later.
Okay, and we can see that it's grown. We can see the cartilaginous cap. We can see that the periosteum doesn't look too bad. It's lifted, but it's intact, I think. Definitely grown up.
It's nice and smooth, isn't it?
Yeah, it looks smooth.
And it doesn't look like it's invading in any way.
Right. So I'm guessing they were going with just growth of an osteochondroma and not malignancy.
Yeah, this was not malignant. Exactly. Good. But it's one that I'd be a little bit concerned about. I'd want to keep following it pretty closely.
That was there's a little bit of a change with hormonal change at that age, and there's increase in growth at 11, 12, 13, and then there's a little, during that period of time, there's a growth spurt, and then it quiets down. That's it with girls. I think boys is a little later. So I think that's why it got larger is because of the hormonal stimulation,
I think you're right.
just like the rest of the bone.
All right, so here we have a coronal and sagittal image of the knee, and we can see a lobulated cystic appearing lesion in the distal, kind of in the metadiaphyseal region, probably most likely an enchondroma.
This is one chondroma. We'll see some low-grade chondrosarcs later, and we'll talk about ways to differentiate the two. This one has a kind of a popcorn type edges, which is very typical of enchondroma. The edges are pretty sharply defined in this particular case. So this is a typical benign enchondroma, and we see many of them.
And this one goes to the cortex too. Usually you don't see them that way, do you, John?
That's correct. Usually they don't go to the cortex. That would make me be a little bit concerned.
Yeah, me too. That's because I'd call you on this one, John.
Okay. Okay. Michael?
45-year-old with acute subscapularis tear and incidental bone pain. So kind of in the proximal humeral diaphysis, we see this expansile, looks like essentially cortically based lesion with some inside sclerosis and some mixed lucency. So, I mean, sometimes you can get tugged lesions that look somewhat aggressive like this, but I'm not sure what would be tugging there. So, you can see marked cortical regularity and expansion and all this kind of lucent cystic change in the cortex. But the overall margins around that look somewhat smooth.
So what do you think?
How they're.
It looks a little bit cartilaginous here.
Yeah, so.
But it's really the cortex. It's really
yeah, it's cortically based.
Periosteal based lesion.
Yes, correct. And they're 45, so. Yeah, I'm not. It doesn't have like fluid levels. It's not really purely cystic. Oh, periosteal I don't think I've ever seen a periosteal
chondroid lesion, and it's involving the periosteum. So this is a periosteal chondroma, and it was benign.
And that cortex is really nice and thick, isn't it?
It is, yeah. These are also called juxtacortical chondromas in this location.
Would you follow this one?
Yeah, I would probably follow it, but it's one I would be less worried about than some of the others we saw. Okay, Ashu.
All right, so this is an 8-year-old female with pinky pain after playing handball. We can see that there are marrow replacing lesions, bright on T2, low signal on T1, mildly expansile within the proximal and intermediate phalanx. And we see that the cortex is preserved. There's no soft tissue mass. There's no expansion. I mean, it is expansile, but there's no periosteal reaction. There's multiple of them. It's also in the MTP, or the metacarpal, sorry, distal metacarpal. So this, I mean, you have enchondroma is probably the most common multiple. Well, it's the most common tumor, most common multiple. Yeah, and you can have Olliers or Maffucci, I guess, would be concerned of.
Okay. That one was just kind of benign multiple.
That's sort of like multiple osteochondromatosis. It's the same kind of a story, but not as common though, I don't think.
Okay. So here we can see that there's multiple lucent lesions in the metaphyses of the proximal femora, the pelvis, the distal femora, and the proximal and distal tibia, and perhaps even the distal fibula. We can say that again. So I'd be concerned about, okay, so here again we can see multiple lesions along the metaphyses. So I'd be concerned about congenital disorders such as Maffucci's or Ollier syndrome. Okay.
so we have a MRI looking at the medial compartment of a pediatric patient with non-fused growth plates, and there's a circumscribed T2 bright lesion in the posterior epiphysis of the medial tibial plateau. And here it is 1 year later, and it's still circumscribed, and it's got like mixed density, kind of low peripheral, and then central T2 bright, and there's probably some edema on the adjacent metaphysis. This could be one of the like chondromyxoma, potentially. Other things could be like a chronic infection.
Would you have waited a year?
Well, this particular image, the person who read this did not notice this lesion. Okay, and then they came back with a little bit of vague knee pain about a year later. So, first, what about this lesion? Where is it located?
Well, it's in the epiphysis.
So, what is that?
In a pediatric patient, so the differential, yeah. You know, one, you can't rule out infection. You know.
Yeah,
No, osteoblastoma is the first thing you think of, right?
What did you say, John?
Osteoblastoma is what he said.
Osteoblastoma.
John, I'm asking Michael. Not
okay. I mean,
you're giving him the answer.
So excluding that one, the other things you think of, you could be EG.
Right. It could be EG.
And these have to be excised and total right from the get-go. You don't wait a year for this.
It could be EG, it could be infection, but both of those typically involve the metaphysis primarily, and then extend into the epiphysis. Primary epiphyseal lesions are pretty much limited to kind of trauma and this diagnosis. Now, how's it changed a year later?
Like I said, it's larger. The signal has changed. There's surrounding hypointensity with central hyperintensity. Now there's a bunch of signal in the adjacent metaphysis as well. So it's across the plate.
So this is a
I'm sorry.
I'm sorry. When I said chondromyxoma earlier, I meant chondroblastoma.
I misspoke when I said osteoblastoma. I meant chondroblastoma.
Now,
I apologize.
Yeah. So this kind of shows progression of the lesion. So initially it's kind of bland. This appearance here with its low in signal intensity around it and this kind of irregular central area that becomes cystic, I've never heard of this in any other lesion but a chondroblastoma. So this is
that's why I said when you see that 2001 or whatever 01, I imagine it's 2001 lesion. You have to remove it. You don't wait till tomorrow.
Yeah. Well, unfortunately, it was missed at this particular time.
Obviously.
We saw it when it at this point, and
I'm surprised it was missed. And the problem is, as you can see in 03, that you have a growth disturbance there, pretty bad one. I won't interrupt anymore, John, if you want me to talk some more. Well,
no, go ahead, talk however you want.
To take care of the lesion in 01 is not that big a deal. What you do is you enter the lesion and you excise in total and block everything that you think is cancerous, and you get frozen sections, etc., and then pack it with bone. Autogenous bone is available. And that's all you usually need, and it'll be fine. It'll heal, and recurrence is not common if you do a good job. 02, you still have a chance to do fairly well and not disturb the growth, although you may have to put fat lesion is removed from the physis. Now, O3, now you have to have reconstruction of the bones, and I think you'd have to wait. You may be able to get by removing the physis and putting in fat, but you might have to wait till the growth is over and then reconstruct.
Yeah, this is post-operative, obviously.
Oh, that's post-operative?
Post-operative.
What do they do? That doesn't.
They remove the lesion.
That's not enough, obviously.
Right. Yeah, it looks pretty precarious here on this particular one.
Yeah. And that's a very tough area to work in.
So early on, these lesions are kind of bland, like we see here, which is what you like. If you wait later, you start getting calcification and you start getting edema within the adjacent metaphysis. That's pretty characteristic. So chondroblastomas are about 1% of primary bone neoplasms. They're always in the epiphyseal location. And later, they develop association with marrow edema, and then about up to 50% can be calcified, depending upon at what stage you make the diagnosis. And they tend to involve the long bones, and they're not that uncommon. We typically see a couple a year here, just and then yeah. The location is really the key. Okay, Ashu.
24-year-old male with lateral knee pain for 1.5 months. You can see primarily lytic lesion involving the lateral femoral condyle. You can't really see the cortex very well along that edge when you need to get some MR.
Involving the periphery of the metaphysis and the epiphyseal region of the bone, though the growth plate was closed. This is an adult, but this marginal area is kind of helpful in its location. It's not a pathognomonic, but it's a little bit helpful. And then here we can see the MR scan.
Okay, so here you have a kind of like a heterogeneous lesion with multiple cystic change, almost like I almost feel like there's fluid levels there.
No,
I could be wrong.
Okay, so this is a T2 and this is a PD fat sat. These are kind of bright on the PD fat sat. They're also bright on the T2, but
yeah.
They'd be a little bit low on the T1s, but kind of intermediate on the proton density.
Okay, so they're not fluid.
T1.
Okay. Oh, I see. So is this like a cartilage, chondroid?
Yeah, these are cartilage. These are parts of
yeah. It looks like chondroid matrix there. So this looks well defined. I don't think this is invasive. There's no periosteal reaction. This looks like more of a benign type.
Certainly destroying bone.
Well, the cortex is involved.
Yeah, that's true.
But we don't
I guess
see it extending out into the soft tissues. And this is a Chondromyxoid Fibroma, which is a benign lesion.
Just based off the plankton on those.
But these need to be excised wide. So, but you saved the leg anyhow.
Yeah, this certainly giant cell would be in the differential on this one. You don't really see an expanded cortex here very well on the plain film. We can see that a little bit better on the.
This has to be excised with the cortex, so you have to do some real good carpentry to fix this.
But it doesn't have the typical MR signal intensity of either an aneurysmal bone cyst.
That's for sure.
So really, these really are more cartilaginous foci. So this was a chondromyxoid fibroma, which is, in my experience, a very rare lesion.
Can you differentiate this definitively from a chondroid sarcoma?
The The only way you can definitively differentiate these is by pathology. You can make an educated guess on MR, but there's really very little in MR once you get solid masses that are reliable at differentiating the histology. There's some examples, there's some exceptions, but not many. So you really, histology is really the key.
It would seem to me that this would be a painful lesion because the cortex is absent, and distally, the chondro articular surface is damaged at the joint space on the left image. You can see right there. That would be painful as far as I know. I'm surprised that this patient lasted this long without seeing somebody. And that's not an easy one to fix.
Okay, so here we can see kind of a lobulated signal intensity structure in the diaphysis. I think this is most likely an enchondroma. I guess it also could be a bone infarction.
You don't see a double line sign, do you?
There's no double line sign, and you have these very kind of popcorn type periphery here. And there's the lateral, and this was a Diaphyseal Enchondroma. Okay.
This is not the same patient. Okay, well, it's a similar appearing kind of mixed sclerotic, fairly circumscribed lesion in the distal femur diaphysis. This one looks a little different on MR, as there looks like there's some edema actually, superficial to the cortex. Maybe it's kind of mildly expansile as well. But I'm wondering, well, it still kind of looks like an enchondroma.
Call this an enchondroma. It's okay. But let me, it's important to look at this differentiation. So this is an enchondroma. Couple of things that we can see here. Basically, it's that serpiginous margin. You can see that there's a little bit of fat going into it. I'd like to see more fat in the center here for me to really feel comfortable that it's benign, but this was a benign enchondroma. And as opposed to this appearance. Now notice this appearance, you don't have that kind of popcorn periphery. The periphery is, you have a much more of a homogeneous type pattern with kind of a central calcification. And then the big thing here is you've got periosteal reaction and fluid in the periosteum. This is a malignant lesion. They look very similar on x-rays, but this is a chondrosarcoma. And so look at the hair, and let's go back. That's an enchondroma. And this is a chondrosarcoma. So this lesion should make you be very, very concerned. And we can kind of describe it, but the best thing is just to kind of picture the difference in your mind. Okay, so when you get to chondrosarcomas, there are many different types. So it's and a lot of these are based upon histology. We'll go through some of these, but I don't think you can reliably differentiate the different types just based upon MR appearances. So let me see. Ashu, what do you think of this case?
So 51-year-old male with right knee pain for 3 to 4 years, has a past history of tonsillar cancer. We're looking at the medial aspect of the femoral condyle there, spanning the epiphysis and metaphysis. Looks like a lytic lesion, partially expansile.
Very
I'd like to,
it looks like
yeah,
the margin is really kind of intact, but you can actually see the trabecular bone in the middle of this. So it's not a typical destructive lesion which destroys the trabecular bone completely. Here's the MR.
All right, so we kind of see some increased T2 signal here, low T1 signal. Again, almost looks like chondroid matrix here. There's actually some fair amount of marrow edema within the lateral femoral condyle as well. The cortex is broken in several spots. It expands into the soft tissues. There's a lot of edema within the soft tissues. I'd be worried about a chondrosarcoma.
And edema in the bone here. Notice on the T1 weighted image, it's not that dark, so there must be something in it that has a short T1 time in it. And then here we can see other images again. Often we use the presence of increased signal intensity on T1 to show that it's a benign type lesion, but chondroid lesions can look different. Here we can see a lot of inhomogeneous enhancement within this lesion. There's the CT scan. So this turned out to be different grades, but the highest grade was a grade 3 chondrosarcoma in this particular case.
Do you know what they did with it, John? Or
Yeah, they curetaged it out. Yeah, they curetaged it and then put in bone grafting. So locally
We have a 39-year-old male with painful limited range of motion for 10 years, but he denies any history of trauma. There is some periosteal reaction kind of along the medial aspect of the humeral neck. And there's some osseous hypertrophy posteriorly. I would think this could be remote trauma, like myositis ossificans. Or
So what would you like to see next?
no trauma history?
I'd like to see the MRI. Okay, so this looks more suspicious because there's intermediate T1 and increased T2 signal. So this may be a chondrosarcoma. Yeah. It does look like there is some enhancement as well. So here again, we can see it has increased T2 signal and it's exiting the bone.
It's obviously a solid mass.
It's probably some cartilaginous components, and there is some intrinsic enhancement. So chondrosarcoma.
So these are about 4% of chondrosarcomas, typically in the third to fourth decades. Okay.
Okay, so I think I see a lesion within the femoral head right there. That's kind of circumscribed, and it's got some, dense components to it. But from what I can tell, it's fairly circumscribed. I can't really see what type of matrix it is. And so now we're looking at, like I said, it's a very well circumscribed lesion with kind of T2 bright and T2 dark mixed matrix within it. It doesn't really look like it's involving the cortex at all.
We say T2. I mean, these are fancy
Well,
images. I don't think we have a T2.
Not T2, but like, fluid sensitive sequence.
That's right, because
these are stirs, I guess technically. Yeah. So I think this is a chondroid matrix.
Yeah, it kind of looks like that kind of.
And I'd say that's like a benign chondroid lesion, probably like maybe enchondroma. And this one it's very hot, or there's extensive radiotracer uptake on the bone scan. Oh, this is a chondrosarcoma. All right.
So once you get in the category that it's not a clearly benign lesion. Like most enchondromas, we can just call them clearly benign. But outside it, fortunately, they're common. Fortunately, they're by far the most common chondroid lesions we see. And once it's a lesion that you can't really say this is definitely benign, then it's always best to err on the side of caution and get biopsies.
So what on the MRI would, because this looks very circumscribed and there's not a real surrounding edema.
It does not look like an enchondroma. Since it does not, I don't see fat in it. The margins aren't that spiculated popcorn type margins. So this would be a non-definitive lesion, and it has to be biopsied. You've seen a lot of enchondromas, and usually have fat growing inside those, going into those. With any lesion like this that doesn't have fat going into it, you've got to say it's not really a definitive lesion. Even these sharp margins, this is pretty characteristic of chondroid sarcomas. Fairly sharp margins and this chondroid type appearance on the signal intensity. So this would be a lesion that would not be definitively benign.
Excisional biopsy.
Okay, the typical malignant risk factors that have been described in chondroid lesions are pain. Generally, benign lesions aren't painful. Of course, you can have other causes of pain. Scallop cortex and greater than 50%. This last one didn't have that, which is separate from the popcorn type areas. And then if it's associated with a soft tissue mass, as you know, that's a bad sign, or periosteal reaction is a bad sign. So, why don't we stop here and we'll start the osteogenic lesions tomorrow, okay? And we'll start this topic.
Okay, John.
Thanks, everybody.
Everybody have a good evening.
Thank you.
Thank you.
And take care. Drive carefully.